Thank you for your kind introduction. Today's talk is about CSP, CRT in heart failure, and let me start with the pivotal historical trial, MEDIT CRT trial, which compared BIB CRT to ICD only in patients with heart failure with less than ejection fraction 30% and wide QRS. And as you can see, hazard ratio show heart outcome reduction more than 30% in patients who receive CRT compared to ICD only. And surprisingly, the hazard ratio in patients with LVBB is less than 0.5. But there is still unmet need in traditional BIB CRT because some patients have very difficult cardiac vein anatomy, so bleed cannot be delivered in 5 to 8%. And even though the position can be achieved, but some patients have suboptimal position in 15 to 20%. So non-responder rate is usually 30 to 45%. So recently, the conduction system pacing was introduced, and it consists of his bundle pacing and left bundle branch pacing. And combined with BIB traditional CRT, we call it as cardiac physiologic pacing. And actually, the BIB CRT is not truly physiological pacing, but if we can recruit conduction system and we can pace this system, then we can make very narrow QRS in his bundle pacing and RBBB, but LV synchrony can be very improved and optimized by this pacing. So this is more physiological than BIB CRT. And this is conduction system pacing and QRS duration in RB pacing and BIB pacing and his bundle pacing. It is almost similar with native narrow QRS. This is some data, and there is surprising data in patients who underwent CSP CRT when compared to BIB CRT, and CSP CRT have much more better QRS duration reduction and much more better LV ejection fraction improvement compared to BIB CRT. And this is some other data, and this in patient with LVBB, this is delta QRS reduction, and this is mortality. There is very significant linear reduction between QRS reduction and mortality reduction. And another advantage of CSP CRT is that this CRT modality have multiple options. This is BIB CRT, and this is usual conventional CRT, but when we can recruit his bundle pacing and we can make narrow QRS, then we can use his bundle pacing CRT as this one. And we don't have to pace RB lead. And sometimes LVB area pacing CRT can be achieved, and sometimes CSP lead and traditional LV lead both can be used, and this is called as optimized CRT when we use CSP and LV epicardial pacing. And this optimized CRT is theoretically perfect electrical resynchronization strategy because some patients have intraventricular conduction delay, so only one strategy can make perfect electrical resynchronization, but use this both lead can be feasible and safe and provide great electrical resynchronization. But still we need RCT data. This is meta-analysis and systemical review comparing CSP and BIB CRT, and CSP have reduced QRS duration and improved LV ejection fraction and lower NIA class score compared to traditional BIB CRT, but there is only 4 small RCT, and the number of patients enrolled is still very small, and there is no long-term follow-up data. And although the strong surrogation marker, such as LV ejection fraction and QRS duration, strongly associated with mortality reduction, but it is only surrogate marker, but not hard outcome. But BICRT have robust evidence so far because of multiple large RCT and large number of population and long-term follow-up. And there is clear mortality benefit and reduction in heart failure hospitalization by BICRT. So still, we need more data, and this is limitation of CSP. We need more data. And also, in procedural aspect, CSP also have some limitation. His bundle pacing have difficult need difficult implant technique, and sometimes have elevated capture threshold, which sequentially need revision or some other procedure. And LBB area pacing have much more better compared to his bundle pacing, but some patients have distal conduction disease, not proximal conduction disease. Then this patient QRS cannot be corrected only by CSP, but this patient need optimized CRT, which need LV epicardial lead. So this is recent guideline about cardiac physiologic pacing, and in patient with LVBB, still BICRT is first option, class 1. And in patient who failed BICRT because of other reason, then we can try rescue CSP-CRT or bail out CSP-CRT, and the recommendation level is 2A. And as you can see, there is no class 1 recommendation for CSP, and except bail out CRT in LBBB, other recommendation for CSP is still 2B. This is because of lack of RCT data. And so there is no class 1 indication for BICRT in this patient. So this patient group, we are more interested in this patient group. And this is some survey about physician preference and about future direction, comparing CSP versus BICRT. And as you can see, you can see this one. In patient with LBBB, still BICRT is preferred option, but in patient with non-LBBB or patient with AFib who need AV junctional ablation, CSP shows very preferential option. And this is because LBBB has excellent outcome with BICRT, but with non-LBBB patient, we all know that the beneficial effect of BICRT is not clear. So we are searching for the better option. And this is not RCT data, but you can see the effect of his bundle pacing in RBBB. In patient with RBBB, his bundle pacing can make complete narrow QRS and shows excellent result. And LBB area pacing itself is a little bit better than RBBB, native RBBB, because LBB area pacing makes some electrical resynchronization, which is better than only RBBB and shows great results. So there is ongoing RCT in patient with RBBB, and this study will give us many information. And I want to show one case, 64-year-old male patient with ischemic cardiomyopathy. LV ejection fraction was 22%, QRS duration over 170 milliseconds, and RBBB patient. This patient is class 1 indication for primary prevention ICD because this patient have low ejection fraction and ischemic CMP. So we plan ICD, but this patient also have indication for BICRT, but we all know that the RBBB, not LBBB patient have not clear benefit by BCRT. So I tried his bundle pacing, and it shows great QRS duration reduction from 170 to 110 millisecond, and showed great reduction, and echocardiography shows significant improvement in LV ejection fraction, and actually cardiac LV chamber size is similar, because RBBB is in patient with RBBB there is no significant electrical synchrony in LV, but you can see the improvement of RV parameters, and it can make some improvement in whole heart, such as the degree of MR or some other things. And the second candidate for CSP is patient with heart failure and AFib who need AV junction ablation. We have still already have recommendation, two-way recommendation, because we have RCT. This is very famous RCT, APCIS mortality trial, which compared AV junction ablation plus CRT to only medical therapy, and the enrolled patient was very severe symptomatic permanent AFib and narrow QRS. So mean age was over 70 years old. Mean heart rate was not that fast, around 100 beats per minute, and LV ejection fraction was like this. And we used many drugs for rate control, and you can see the surprising hazard ratio reduction when we use ablation, node ablation plus BCRT when compared to drug. But we don't perform this modality not that much, because this modality have significant benefit is strict rate control and rate regularization. It is also very important thing, but we have unwanted lengthening of QRS duration in patients with AFib and narrow QRS. So this is the reason why many EP physicians and other heart failure specialists hesitate to do these things. But CSP can be the perfect option. This is the second case, very old patient, high HEP and had permanent AFib, and had hospitalization in other hospital for 1 month. But the pleural effusion was not disappeared, even though had some medication control. And when we tried to dose up the diuretics, there was creatinine elevation, so very difficult. You can see the ECG AFib. Heart rate is less than 100 beats per minute, and you can see LV anterior fascicular block and intraventricular conduction delay with QRS duration 130 milliseconds. It is not wide QRS, and it is not expected wide QRS LBB patient, which can make some by BCRT benefit. So we tried LOT CRT. We implanted LBBP lead and LV lead and made junction ablation. And this is ECG. QRS duration is a little bit narrow, and symptom was very, very improved, and pleural effusion disappeared and discharged 3 days after this modality. And you can see the NT-proBNP level decreasing more and more. And this is echocardiography. It shows, you can see, very regular heart rate. So this is my second case. And so this CSP-CRT made, CRT protocol very difficult, but I think it can make some simple protocol after some RCT. This is ongoing RCT so far, and this is RCT, is still ongoing in Korea. So this is my final slide. By BCRT versus CSP-CRT, we need more data, but CSP shows promising result and can be an excellent alternative to BCRT. And especially for non-LBBB and for AFib who need AV junction ablation, it has potential to be first option. And in patients with advanced heart failure with non-LBBB or narrow QRS, and sometimes patients with AFib, then we can use CSP-CRT as salvage purpose, and sometimes palliative purpose in very symptomatic HAP lab with usually very elderly patient. Thank you for your attention.